What's up, you guys? I'm Dr. Nick. Welcome to the Soul Circle, where we have 4 amazing podiatrists. We're going to answer foot questions, talk about foot health, and get to the most common problems that we all see as podiatrists. I'm Nick Campitelli. I practice in Fairlawn, Ohio. I have a mixed practice. My favorite thing to work on are bunions. I have a passion for fixing bunions, doing minimally invasive bunion surgery, and I also have a residency program that I'm director of in Western Reserve Hospital, which is in Cuyahoga Falls. Next to me is Dr. Nicole Friels, and yes, she is the Dr. Friels Good. If you haven't heard of her, she has a podcast and YouTube channel.
Yes. So yes, Dr. Nicole Friels from Lexington, Kentucky. I've been a podiatrist for about 17 years, and I'm here to help engage and really educate people, especially other doctors and consumers, on how we can help them kind of virtually. Basically, just giving them an over-the-counter insert or something like that can really make an impact in their day. So I love biomechanics, all of that good stuff. Alan, take it away.
Hi, Alan Bass from Alpha, New Jersey. I practiced podiatry for 30 years. I'm now lucky enough to be retired, but in my practice, we did a lot of sports medicine, a lot of primary care medicine. People came in with a lot of conditions that didn't need surgery. So I worked very closely with them on palliative care. Now I focus more on business management, and I'm happy to be here, and I'd like to turn it over to my colleague, Sarah.
I'm Sarah Holler. I live in Hoboken, New Jersey. I help direct a co-host residency program over there. It's fantastic. I do a lot of arthritis. I do a lot of trauma. So those are the main parts of my practice. I'm really busy. I love to work with my residents and really engage with my patients on a daily basis.
Awesome. Well, I hope you guys are excited to hear this. We have a wonderful group, as I had said. We're going to kick this off with foot facts and myths. So Dr. Allen, let's get us started. Going barefoot, is it better for foot strength, or should you have something on your foot?
I always think it's better to have something on your foot. I think if you have a well-contoured shoe, well-contoured sandal, something, people are under the misconception that a lot of times gripping the ground with your toes is better for you. It can strengthen the foot muscle, but I think a good supportive shoe or insole is probably best for you.
Dr. Har.
I concur. I do believe in the whole grounding thing. I'm, into that whole mindset. But I do believe that, like, if I'm walking around doing something outside, no barefoot running for me. I'm not doing that whole mindset. I really do believe you need a supportive arch, a good forefoot striker, and a good heel counter.
Yeah.
Absolutely. I think there's a time and place to be barefoot. If you're going to be lounging around the house, that's okay. But if you're going to be active, cooking, cleaning, running up and down the stairs, you absolutely need to have a tennis shoe on. For me, anyway. I always have a separate pair of tennis shoes in my house. So it's easy, and you can really mitigate a lot of foot pain by just those little areas.
So I'm a little different with this philosophy. I kind of go against the grain. I believe in the whole barefoot philosophy, and I think it does strengthen your feet. We actually published a study out of our podiatry school. It was OCPM at the time, but we showed that when you go barefoot, you can increase the girth or the muscular function in the foot by making the muscles larger. The problem is if you're doing it too soon or you're going barefoot too much, it can create a problem and create an injury. So I think if you use it as an exercise, it works. And then shoe gear when it's appropriate. And, I think shoe gear and orthotics, something to give relief to your feet when you're on them all the time, is definitely necessary. So I think when people misuse barefoot strengthening, it can be a major problem.
I kind of put a time to it. So if you're going to be on your feet, I'm talking to my patient, longer than 20 to 30 minutes, I would go ahead and put a shoe on. Especially if you're prone to back issues, like those hard surfaces, really, you're absorbing all of that into these larger joints. And of course, it just builds and builds. So again, I'm a time limit person for mine, because they need something, you know what I mean? They need, like, okay, it's time to put my tennis shoes on.
Mm-hmm.
Sure.
Well, while we're on this, what about plantar fasciitis? Is it true that only older people get plantar fasciitis, or can anyone get it?
Absolutely not. Everybody gets it. It's literally the most common issue that I treat, especially because I treat a lot of laborers, a lot of Toyota workers that are on their feet, and they're just so, like, that concrete and that hard surface, it makes our muscles really tight. And so that, of course, contributes to plantar fasciitis.
It's young, it's healthy, it's active. It's people that run, it's people that don't run. It could be somebody that does, yoga every day and they think they're stretching, but you can still get plantar fasciitis. That's one of the biggest misconceptions is, oh, I stretch all the time. How do I get this issue? But it's literally, you're not maybe stretching the right thing, or maybe it's like your iliopsoas, you're not actually paying attention to your hips. Everything's connected. People don't understand that sitting all day really can cause plantar fasciitis. Even though you're not on your feet, you're still actually causing it.
It contracts everything, back here.
Sure, you're supporting you know, if you're not supporting the musculature of the feet and things are overworking and being pulled on too tight, so anybody can really get it. It's not a young, it's not an old, it's pretty much anybody can get it, active or inactive.
Something I have to tell my patients are they think it's like a disease where I'm never going to get rid of this. You know, you're going to have it forever once you get it. And I think you have to kind of educate them and let them know it's you created it. It's a condition that you created. It's an overused condition. And I think maybe older people get it more because they become more sedentary as they get older and the tendons don't heal as fast. So when a young person gets plantar fasciitis, it sometimes goes away faster. And the older population, they maybe don't heal as fast and it tends to become more prominent maybe in older people.
I think another thing that's important about plantar fasciitis is educating all facets of our patients, the younger, the older, because people are under a lot of the misconceptions that very young children get plantar fasciitis when they have heel pain. You know, you could be treating a senior and, oh, my grandchild has plantar fasciitis. And I think it's important to explain what plantar fasciitis is and what some of the other conditions are that come about as heel pain that they can then relate back to their family.
All right, Dr. Holler, the patient comes in and they're like, my family practice doctor sent me here because I have a heel spur.
Oh boy. All right, so we all say this, right? So a heel spur, just because you have a heel spur doesn't mean you need surgery, doesn't mean it needs to be resected. It's telling you, I tell my patients, it's like looking at the inside of a tree. It tells you how long it's been there, how long you haven't been stretching. I think that's the easiest way to conceptualize it, right? So that heel spur is going to grow on the bottom of your foot. It's attached to the plantar fascia, which rides up the back of your heel, goes to your Achilles. All those things are connected. So if the Achilles is too tight, you're going to have this heel spur syndrome, but it's literally rectified by stretching.
Inside of a tree. That's a good analogy.
I like that one. I tell them it's not like a spike. It's not like you're walking on it like that. It's parallel to the floor and it's also up off of the floor a bit. Of course, it's the soft tissue that's really the problem.
I think the greatest thing when it comes to heel spurs is really discussing it with an x-ray with the patient.
Yes.
Because as Sarah just said, a heel spur will really tell you how long that patient has had it. If somebody comes in with newly, onset heel pain and there is no heel spur, it's a much easier discussion than you've had this for so long. Because look at this big, what looks like a hook on the bottom of your foot, which tells us the rings in the tree, how long it's been there. So I think it's important to talk about this with visual aids to your patient.
But we don't have to cut the tree down.
No, 100%.
You remember it in elementary school.
I remember. No Lorax. All right, Dr. Friels, your turn. Cracking your toes. Can it create arthritis?
No, but I'm sure there are other people. I would love to hear everyone's opinion on this. I don't personally think that. I mean, it just releases some synovial fluid.
Toes?
I mean, not like a daily basis. I mean, if it's, it's there, I guess I crack it. I mean, are you a habitual cracker?
No, I'm not.
Okay. Yeah. I mean, so in terms of like joint damage, I don't really think it's going to be doing anything major because of course the fluid's there to protect the joint. Yeah, that's my opinion. I don't think
people are under the misconception that cracking your toes or cracking your fingers is causing some type of an arthritic condition. The fluid is contained within the joint and is going to be there and is still protective. I think that's a big myth.
I agree. But I think like some people, I wear in yoga class, for example, you're in a happy baby. I definitely do bend my toes down. And I do feel that. Cause like after you've been on yoga and like a hot yoga fuss.
Hot yoga.
I think we need a demo.
Yeah.
Here's the table.
All right. I feel it.
So you can bend your toes down. You feel that, and it does feel like it's like a good release after you've been stretching for an hour.
Okay.
Yeah.
Learning things.
Cracking though, a lot of my patients will ask me when I go up and down the steps, my ankle pops.
Yes.
Is that bad? Is that healthy? Is it unhealthy? Is it a predictor of something? What do you tell your patients when they tell you that?
So I do immediately, I'm like, we need to do an anterior drawer sign. So if you had instability, whether it's like, I think the CFL can be unstable and I think that can cause instability, even though it's like the subtalar joint, which is, patients don't understand what a subtalar joint is. So I think that's a whole misconception of like, there's my ankle. It might be your subtalar joint. It might be your peroneal tendon that's actually popping over and subluxing. So I think it makes for a good conversation, a good clinical exam.
Yeah, I'd agree because, patients know about their ankle joint. Patients don't understand that you have another major joint in your foot that does something completely different that has to be looked at to make sure we know exactly what's going on with the foot.
And I try to teach my residents and students this. Have the patient point, say, take one finger and point at your
One
foot
finger.
and tell me what hurts, because they might come in with ankle pain and it's the TN joint. But as a student or early practitioner, you're honed in on ankle pain because that's what the patient said, and you're looking at their ankle and you're telling them their ankle's fine, but their TN joint might be very arthritic.
I mean, as long as you know your anatomy and they point to it, it's a no-brainer. I mean, you've narrowed it down to probably 2 diagnoses.
Yeah, but how many times do our patients do this?
Because that means neuropathy.
One finger.
Fibromyalgia.
Yep. Exactly.
The 2 hands pulling the ankle.
Yeah.
Exactly.
I'm like, if you had to pick one finger.
So let's talk about orthotics. Custom orthotics or insoles versus just insoles. Do they have to be custom? Can we just use an over-the-counter insole? What are your thoughts on that? Dr. Nicole, I'll talk to you first.
I think starting with an over-the-counter is probably best to kind of get an idea of what's comfortable to the patient. Because I really look at the materials and in terms of evaluation, like what do you do for a living? I mean, all of that is so important. What shoe, has to be realistic for the patient for them to be compliant. So if they're like, hey, I wear ballet flats. All right, well, let's do something. Let's grab an over-the-counter, see if we can't get you some support. But then I typically do transition them into a custom, especially if I know that they're going to be really wearing and tearing on these OTC. So we just need something a little more, in terms of durometer, of density, the materials in there that need to be more robust for people that are just pounding on it 12 hours a day.
Big word, durometer. I've heard you use that recently. I don't know what that means. Can you?
So basically, if you think of an open cell versus a closed cell material, a higher durometer is more dense. It's like a lower durometer is more loose, kind of more foam, a little softer, a little more shock absorption to it. So, if those cells are larger, then you're going to get more shock absorption. They're smaller. Brooks has an awesome shoe. It's a dual. They do closed and open cell materials. It's a new product they've just came out with. It's really, really comfortable. It's in their glycerins.
Go ahead.
I use both, right? Like I put my patients in, when I was in residency, like they taught us, like most people do really well with an over-the-counter, which I'm sure you guys use. Most people with plantar fasciitis can just use an over-the-counter. It's the specialty foot types that are, require a little extra love.
Sure.
They have arthritis in a certain place. They have, high ankle sprains consistently. They need a different kind of orthotic, and that might require more custom.
Yeah.
I think what's the biggest thing that we have to educate patients on is what they think the proper insole or orthotic is. They could say that they've used an insole before, but what have you really used? Have you used something that is flimsy? Have you used something that has some support to it? I will tell you that patients who came into my practice newly onset that really have not had problems with their foot before, they do very well in a prefabricated orthotic like a PowerStep orthotic because it's made well. It's those that may have had prefabricated before that need something more. I always tell my patients, we're going to put you into a PowerStep orthotic and you'll feel great. You might feel like you need a little bit more help. We can always then transition you to something that's custom. How did you do it in yours?
Well, as we call this practicing medicine, we all do things differently when we're practicing. And I guess here's my involvement with orthotics, or how I implement it in my practice. I tend to use more of an over-the-counter, and PowerStep is my go-to. I mean, we're here talking about PowerSteps. How did I learn about PowerStep orthotics? It was just, that's what our practice used. When I moved into this practice in Streetsboro, Ohio, that's what was in the practice, and I knew it as a student and resident, and I kind of just thought, well, that's the over-the-counter that we always use. And it was always my go-to. So if you look at the studies on using an over-the-counter versus a custom, it depends on what you're treating. If you're treating plantar fasciitis, you can get the same result with an over-the-counter. So that's kind of how I implement it. If I'm treating something that needs a custom insert, such as an accommodative orthotic, like a person might have a plantar flexed ray and they're getting a callus and I want something to offload a certain area, I might order an accommodated orthotic that's going to be made, at a durable medical equipment store that's accommodative. Mm-hmm. If I want something rigid, then I just try an off-the-shelf PowerStep orthotic. And I also think the way I've approached it is, if I'm making an insert for someone with plantar fasciitis, because when we treat plantar fasciitis, I'll just use this as an example. For treating plantar fasciitis, sometimes we don't know what's going to make it better. I mean, we know stretching helps. We know there's a whole toolbox of things to use, night splints, injections, NSAIDs, etc. But if I prescribe a $500 orthotic and the person doesn't get better and doesn't follow up with me for other treatment options, then they're going to blame the insert for not making them better. So I would rather use an off the shelf that's less expensive and more affordable and start there and then educate the patient and move on with my.
I mean, you'll agree that I think educating your patients in what is a proper insole or a proper orthotic, because they may have a misconception of what they've been using is the best. And now I need something custom. And they've been using something that's very flimsy or very flexible, and we never gave them what they need. I mean,
There are so many different over-the-counter inserts out there. They're grabbing anything and everything. Whatever's on Amazon, that's what they're ordering in. They come in, they're like, oh, I've already tried inserts. These don't work. Well, these don't work.
Man, right?
And so I'll pull it out and, flex it. It's like there's no support to it. I'm like, you're too young to be wearing this insert. That's why I tell them, like, oh, I'm too young. I'm like, yes, you need something that's going to be for an active person. I'm like, that's for somebody that's sitting in a wheelchair all day. So you need more function behind an insert, and they're just not all the same. I mean, it's all over the place.
Agree.
A lot. I don't know. I feel like a lot of people come in with all these inserts, and like it's all about education. That's all it's about. At the end of the day, like you want them to get better, and like if they leave your office and they're not educated, I feel like I did a bad job.
Yeah,
I need to make sure that you leave, and like my job is to explain it to you so you can go home to your significant other and be like, this doctor told me everything I did to know, and like, oh, this might actually help you as well.
And if they're not getting better, they're going to come back to you. If you just give them an insert and say, go home and wear this, it's going to fix your foot pain, and it doesn't, they're probably not going to come back.
Especially if they've invested in a large amount of money for something, they're not, the trust is gone at this point.
Yep. They're like, I already spent $2,000 on over-the-counter inserts or orthotics from an unknown company. We will not name that. But they've already spent that money, and they've got new shoes. This is not helping. Exactly. And so they're coming in already saying no. They've already got this negative connotation about an insert. And so it's our job to like, okay, let's talk about this insert and why it's not helping you, and just make it like personal.
Yep.
Cool. Let's talk about bunions, my favorite thing to treat. Sarah?
Oh boy.
Do you know why it's called a bunion?
That's actually a great question.
Paul Bunyan. It was named after Paul Bunyan.
No way. Lies. Oh.
So the question we have is, do high heels cause bunions? I don't wear high heels. I mean, I've tried them on with my kids and my wife, but I don't typically wear them all day. Dr. Nicole, do bunions result from wearing high heels?
Not a result of. Does it make you more likely to develop a bunion? Yes. You're balancing on the ball of the foot is going to splay. Absolutely. But is there a direct connection? No.
You're bypassing me on the high heel question?
I'm looking at
No.
But you have 90 minutes. Let's go. Let's hear about bunions.
I'm going to leave it to my colleague to my left.
I love the stiletto. I think they're beautiful, and I do not believe they cause bunions. I believe that it's inherited. Mom, dad, grandma, grandpa, it's all inherited. So I can wear whatever shoes I want. Is it going to make my bunion worse? Yes, probably. Is it going to give you more of an arthritic bunion? Yes, I do believe that will happen, because as you walk on the ball of your foot, you're jamming the first, the proximal phalanx into the metatarsal head, which creates an OCD lesion, which precipitates into osteoarthritis.
I have OCD too, thanks. So you nailed it. That's what I tell my patients. And I think it's important to tell them that they didn't create their bunion, because some, and I'm going to use women, because they're always, oh, thank you. It wasn't the high heels that I wore my whole life, because they feel better when you say you didn't create this. And I think it's absolutely genetic. There were some studies that looked at unshod countries, people that don't wear shoes, do they still get bunions? And we know they do. And my daughter, who is 17 now, she was born with a bunion on one foot, and we've watched that bunion develop over time. And we know that she wasn't wearing high heels. So it's definitely not caused by high heels, but yes, it can aggravate it, maybe make it a little worse.
Yeah, I think educating your patient that there are many factors, and wearing a shoe that might be a little too pointy and putting some tension on that big toe joint might be a contributing factor, but not the main factor.
So what about insoles for bunions? What do you think about that? Would you have your patient wear a wider shoe, put an insert in? What are your thoughts on that?
I tell them, like, honestly, like, it doesn't, I mean, a 4-inch stiletto, I don't know if you guys have ever put that on.
Say no.
Very hard to put an insert into that. Yeah. So I tried to put with like the little Velcro in the back of them, the sticky, it just doesn't stay in. I can fit an orthotic and over the counter, like a slender fit from like PowerStep or something like that inside of like a 2-inch heel. But other than that, I can't get anything in there.
Yeah, I mean, your foot is so, when we talk about biomechanics, it's so biomechanically unstable when you're putting it into a 4-inch stiletto that really, I don't think no matter what you put in, you're really putting the foot in a better position. I think the foot is what it is. And maybe you're just trying to help a little bit, but no matter what, I don't think it's going to change. I mean,
100%, completely agree. Honestly, not a lot to add because it's not going to work. You put in, and I have actually built like, different shoes, not built them, but I had them ordered, different shoes that are custom to the patient with an insert in there, like already built into the sole, and they love that. So if you have the money and the funds to do that, I would highly recommend just having it custom made for you if you're addicted to wearing your stilettos or whatever shoe, you're an attorney and require that type of shoe.
I think patients will sometimes ask or come in with the question of, can I use an orthotic to make my bunion better? So when the foot pronates, you can increase the stress to the great toe joint, making the bunion worse. So in theory, putting an insert in can control some pronation, which might reduce the stress to the bunion, but I don't think it's going to fix it. It might.
That's why I tell patients, you've got to support the arch. Otherwise, you're going to continue to pronate, you're going to continue to roll over the first MP joint, and it's just going to continue. So if you want to stop it, I tell them, I can't reverse what happened. I can't make the bump go back, but we can stop what's happening as much as we can as long as you're wearing it, much like your glasses. You wear your glasses, you can see. Wear your orthotics.
I think we'll all agree that it's about educating.
Yep.
No matter the condition, I think it's about educating our patients and making sure.
The why. What's the root of the problem that happened, and how do we get to that point, address that, and control it the best we can given what we have in front of us, and then moving from there.
What about age? Does age necessitate an insole in your shoes? So do older people need to have insoles? Do younger people need them, or are they only for older people?
This is the craziest thing. So I see a mixed variety in my practice, right? So I tell older people when I see them, the only place you lose fat as you get older is on your feet, and it's unfair. So I naturally put my older patients, and that doesn't necessarily mean old as in I think 40 and up. I think we are young, right? But at the end of the day,
hold on.
Not the same, right? But I think I've worn an orthotic since I got one over the counter when I was a student, right? And my feet feel better. So why wouldn't I do the same thing for my 18-year-old versus my 86-year-old? Everybody deserves support. Depending on what you're doing, it's just a different variety. But I do believe everybody needs some kind of insert.
Yeah. Go ahead.
So my wife was doing something for our kids, and one of the questions was, does your husband do any charity work? Does he do any volunteer work? And she goes, yeah, neighbors come over all the time, and he'll help friends out with their foot problems. So this leads me into this. We had a patient call our office, and I'm sorry, not a patient, call my phone as a friend of mine, that his daughter is 17, runs track, and has been to all the physicians in the area. She has shin splints. It's going on and on and on. He's like, can we have her come into you to get into a pair of custom inserts to help with her shin splints? And I'm like, you know what? I'll bring a pair of PowerSteps home. I'll give them to my wife. She can bring them into, they're teachers. They work together. And, she's 17. So that's kind of where we started that process to see if it makes any change. So that's another way where I'll use insoles in younger people that are runners. And you don't want to break the bank in kids with their parents saying, we bought you these expensive shoes. Now we have to put you in a $500 insole. I think that's an ideal way to sometimes try, because kids now are active. They're going from sport to sport to sport.
Yes.
I almost called you Dr. Bass. It's all about the Dr. Bass. So I know your practice, you saw a lot of children would always say.
So one of the things I always like to tell people is the world is made of concrete. The foot is not made to just function on concrete. So whether it's a 17-year-old athlete or a 77-year-old patient, I think everybody would benefit from some type of good supportive insole or orthotic, because nobody has a perfect foot. The foot always would need some help with something. And I think that's an important thing. I'm going to say it again. It goes back to education. It goes back to making sure patients understand how your foot functions and how it affects your daily life.
Runners will sometimes tell me, I tend to run on asphalt because it's softer than concrete. And my response is, if I made a hammer out of asphalt and one out of concrete, would it matter which one I hit you over the head with? You know, they're both hard. You know, you
But
think,
there's more give to the asphalt than the concrete against that cellular connection.
I guess, but if you're doing 20 miles on I don't know. I looked at the whole barefoot thing as your foot's responding to the surface. So I think it's not the surface itself. I think it's the change in surface. So if your runner was always on asphalt and then decided to do 20 miles on concrete,
There you go.
you'll see an issue.
Well,
I think
that's like I said to patients, if the world was made of sand, I'd be out of business. But the world is not made of sand, so we have to deal with what we need to deal with, right?
personally, I've been in orthotics since I was 8. And it goes back to the genetic component. Like we were talking about the bunions and whatnot. So I look at the foot type. You know, the age is one thing, but really the foot type and what we're dealing with is what I'm focused on. And is this appropriate for an over-the-counter? Is this a custom? What are they doing? Again, bringing the whole body together and just really customizing and personalizing that insert for that person.
Anything to add, Dr. Holler?
No, I mean, like, I feel like it all depends, right? It's just like some of my patients, like, they benefit from custom, they just over the counter. I think it all just depends on what you're looking at. I said 17 to 70.
And what their goals are.
Yeah.
You know, what do you want to do?
Bass, you brought up sand. You know, it can have the opposite effect too. Sometimes when patients go on vacation and they're walking in the sand a lot and they think it can stress the peroneal tendons and it can end up with tendonitis. So back to education again.
100%. I always, you know, I say that's why I tell my patients, we're treating you for possibly whatever condition. You know, even when you're walking on sand, you know, making sure you're not in a $2 flip-flop from a local store, but being in a supportive type of sandal or flip-flop like PowerStep has, it's going to not let you, what I always love to term is get on the hamster wheel. We'll get you better doing all these good things, but then you're going to go on vacation and not have the right footwear.
Right,
You're
that's
gonna
an
set
easy
yourself back.
That's an easy problem to solve because they're like, I can't wear these on the beach. Well, just get a better sandal to wear on the beach.
Exactly.
I take it to activities. Like, are you walking a mile, 2 miles on the beach? Like, what are you doing? Then I would recommend a brick shoe if they're going to be going that far. Now, if they're a sandal, kind of more, playing with the kids, that type of thing, running around, but just not too much activity.
Yeah.
All right, that wraps up our first segment on foot facts. Stay tuned for segment 2. I'm not going to tell you what it is.